Ali, can I examine Sadaf?
Yeah, sure. Go ahead.
Okay. So I'm going to greet the child. Hi, Sadaf. How are you doing? And I'm going to clean my hands along with as well.
Sure. Okay.
Is
Yeah.
okay. So I will ask him to walk for me. Can he walk?
Yeah, he can walk for you.
Okay. So good job. So I will check the weight and height.
Weight, height, head circumference, okay, are normal for the age.
Okay. Then I'll ask him to perform a Gower sign to check for any evidence of proximal myopathy.
Mm, okay. All right. So there is Goversan is not there.
Okay. Then ask him to sit down and I will check his vitals, heart rate, pulse, respiratory rate, temperature.
Temperature is normal, okay. Pulse rate is 110 per minute and kind of low volume, you can say. And blood pressure is normal. CFT is 3 seconds, and yeah, blood pressure is normal.
So any signs of any leukonychia on nails or any debridines contractures on hands,
No, not there. So some
any
pallor is there.
bruises,
No bruises.
okay, any jaundice?
Uh, where do you want to look for that?
Uh, I- I'm going to look for that in the eyes.
Okay, so it's not there.
Okay, then I'll examine the oral cavity. Is there any, how is it dental hygiene?
Oral, it's a dry, mouth. Yeah. Otherwise, dental hygiene is okay maintained.
Okay, so I will check for any lymphadenopathy, cervical axillary.
Not significant.
Okay, then I'll ask Sadaf, can you please lie down?
Mm-hmm.
I will ask him, is there any pain anywhere? And when if there's no pain, then I will proceed. I will do general. First, I will do superficial palpation, then deep palpation. Is there any pain or tenderness anywhere?
Which system do you want to examine?
Now I'm doing GIT,
Abdomen. Okay, sure.
abdomen. Yeah.
Okay, so yeah, all right. He's having tummy pain in sometimes. Otherwise, okay.
Okay.
Mhm.
So, is there any tenderness when I'm doing deep palpation?
You want to start with directly deep palpation? No, no, you don't want to do
No, no, I
any
did superficial palpation. I asked you, I did superficial palpation inspection. I've done the inspection. This
superficial
because
palpation.
there was
What you
picture.
want to look for? What you want to look for?
Any tenderness, any guarding.
Not there.
Okay. Any visible strias on the abdomen.
No, not there.
Is the umbilicus protruded?
What is that? Sorry.
Is the umbilicus protruded outwards?
Yeah, it transversely stretched and this. Yeah.
Okay. Then I will do deep palpation,
Mm-hmm.
and then I will do look for organs. So can I palpate liver?
Liver is not palpable.
Okay. Spleen.
Spleen is also not palpable.
Okay. Then I will check for fluid evidence of fluid, so shifting dullness.
Okay, so shifting dullness, it is present.
Okay, and fluid thrill.
Not there.
Okay. Then I will ask. I will go to the foot end and I will examine the foot as well, and I will look for any evidence of edema on the foot as well. Is there any edema?
Pitting edema is present.
How? What is the extent of edema?
Okay, it is involving lower limbs. Okay, yeah. Where else you want to
Okay.
look for?
No, till the thigh. Okay. So I'm going to check. Now I'm going to ask him I'm going to examine the back. So is there any sacral edema?
Yeah, some edema is there in the secretary
And
also.
I'm going to auscultate the uh, lung fields. Any edema? How the breath sounds?
Right side, it is decreased in the lower area, lower lung field area.
Okay, and left side.
Left side is okay.
And then I will check for blood pressure
Is normal.
and heart. Any added sounds or muffled sounds?
No muffling of the heart sounds.
Okay, then I'm done with the examination.
So could you please summarize your findings and tell the
So
diagnosis?
I got chance to examine Sadaf, who is not in distress, vitally stable, no dysmorphic facial features, although there is periorbital edema. There is no evidence of proximal, evidence of any steroid toxicities there. He has distended and evidence of free fluid in form of distended abdomen, and pedal edema. Lung sounds are also diminished. Other than that, blood pressure is normal. I would like to examine the genitalia for any genital edema as well. But keeping them in mind the dignity of the child, I will only offer it right now.
What is your diagnosis?
So it's a most likely case of nephrotic syndrome.
What are the differential diagnosis?
Differential diagnosis would include protein losing enteropathy, although I did not find any evidence of micro or micronutrient deficiency other than pallor.
Okay. So nephrotic, what kind of nephrotic syndrome you're thinking?
Uh, the age was 4 years, typical nephrotic syndrome.
2 years, 2 years.
2 years.
Okay.
So still typical nephrotic syndrome.
What do you mean by typical?
Typical mostly presents after 1 year, before 10 years of age. There's no evidence of high blood pressure. There's no evidence of any the our pictures are normal, and also there's no hematuria as well.
What are the types of nephrotic syndrome you know?
So types of nephrotic can be typical and atypical. Typical is presence after 1 year, before 10 years of age. There is no feature of there's no headache, no high blood pressure, no hematuria. Renal functions are normal as well. The biopsy finding is most likely minimal change disease. Atypical can present before 1 year in congenital nephrotic syndrome, or after 10 years of age. 10 years of age, there will be other signs as well, like headache. There may be high blood pressure. There may be hematuria. Renal functions may be deranged. On biopsy, you may find focal segmental or mesenteric proliferative or any other membranous nephropathy or something like that.
So how will you confirm the diagnosis?
So we will do some lab test. I will consult my consultant, and I will order some test after doing taking full history, doing examination thoroughly, plotting on centiles. Then I will do some supportive and specific investigation. So the specific investigation include urine RE. There will be 3+ protein cells. Other than that, PCR would be more than 2. Uh, Albumin would be less than 2.5. Cholesterol would be more than 200. And yeah, other than that, we can also do. Yeah, these are the tests that are required for diagnosis of nephrotic. Other than that, we can do complete blood count because the child was pale as well, and we can do varicella zoster immunoglobulin status because we will be giving steroids, so we have to know the status before we can give varicella zoster vaccine if he is not immunized.
Mm-hmm. Okay,
Other
all
than
right.
that, in atypical cases, we can do ANA, anti-double stranded DNA, and also go for biopsy if required further on after consultation with the pediatric nephrologist and pediatrician.
You want to do a renal biopsy in this case?
No, I don't want to do renal biopsy in this case. But I would like to review previous records. Maybe this is a congenital nephrotic, maybe this is a steroid dependent, then I will. But because I have not taken the entire history, so I can't.
Okay, all right. So what is the further treatment?
So I will treatment. I will advise about the disease course and nature of the disease to the parent and to Sadaf as well, and I will advise them
Sadaf
about
is just 2 years old, fully able to
okay,
understand.
okay, yeah, yeah, sorry. I will tell about the nature course and nature course and prognosis of the disease to the family. There's a good prognosis. 90% is minimal change, so the patient improve on its own. I will start with I will advise them about the steroid card because he will be taking steroids. I will advise them about the sick day rule. Then I will tell them that we will start him on prednisolone 60 milligram per meter square for 4 weeks, and then 40 milligram per meter square for alternate day for the 4 weeks. Along with that, I will give gastroprotection. I will give penicillin for the first 10 days, and I will give varicella zoster on presentation vaccine if he's not already vaccinated, and pneumococcal as well.
If he's not vaccinated, you want to give varicella zoster immunotherapy? Why?
No, because if with in this age mostly people do get varicella disease, so that's
Is
why
it is it
I want to
freely
vaccinate
available?
him because I'll be
Is
starting.
it freely available in UK?
No,
All right. So how do you follow up the child and what you monitor?
how will I follow up the child? So I will do early morning urine dipstick test and blood pressure monitoring, and yeah, diary as well. We'll do abdominal girth as well,
When
and
do you want to? Okay. So when you say the child is responding to the treatment, like no child is in under remission. So what are the criteria?
child is under remission. So what is the criteria?
Hmm.
Sorry, what is the question?
When do you say the child is under remission?
Okay, so if three consecutive early morning protein dipstick is negative trace, then we will say the child is in remission.
Okay. Well, so when do you expect that to happen usually when you start steroids?
Usually by 7 to 10 days in not minimal change disease.
Okay. So okay, all right. You started the treatment. Now child has responded and started taking oral feeds and oral drugs medication. So after that, when do you want to follow first time after that, the initial discharge?
I will follow him up after 4 weeks to taper the steroid.
Okay. What are the expected complications in nephrotic syndrome?
So in Nephrotic syndrome, child can have shock or hypovolemia and shock. He can have infections, he can have infections. He can have like meningitis, spontaneous bacterial peritonitis, UTIs. He can have gastritis, and also it's a thrombophilic disease because of the loss of uh, specific proteins in the urine. So it can also cause that, right? Renal vein thrombosis and
Sure, all right. So let's do the discussion. Okay. Rahman, thanks for
yeah.
the participation. Okay. How was it?
Yeah, I did some blunders, I think. I didn't know what I had to examine because I have given this exam once. So my patient was nephrotic syndrome, and my command was to do general physical examination. So I did everything I did there.
Okay. So now you tell how was it like? What are the things you done well, and what are the things you could have done differently?
The, I I don't know.
You don't know. Okay. We'll ask others, your
Yeah,
friends. Okay. They know. All right.
yeah.
So guys, please help her. So please give your feedback. Let us start with Sarika. Sarika, how was it?
It was good, doctor. So she answered, in fact, all the questions, and um, I think general examination, if it was, I was not very sure, like after the initial how the child is looking, well, alert, syndromic, non-syndromic, anything in the surrounding, then maybe we can just say that as it is a general examination, we start with the hands, then we go through the head, face, neck, and then we see the neck, we see the chest, we see the abdomen, uh, and we see the legs and even the lower limb edema. So basically, the anasalca first is one thing which we will see, and then we can just tell that as this looks like nephrotic syndrome with generalized swelling, I would like to go with the GI examination. And if at all time permits, then maybe the lung basis just to see the crepitations or anything. So I think this was, I don't know, maybe this is the format.
Yeah. Thank you. Okay, then next, anyone else? Dipti?
So I was
Yes,
given the pictures. That's why I did not ask about the dysmorphic facial features, because I saw the dysmorphic facial features and the periorbital edema on the in the picture, and I saw that there were no striae on the abdomen. So that's why I did not ask them when I was examining them. And for Gavarsan, because if it's steroid dependent, the patient will have swelling again and again. He may be taking steroid for a long time, so he may have developed proximal myopathy that is common with steroid.
It is your assumption, okay? It is wrong to do that, okay? I told this is the first
Okay,
time child is coming like this, okay, with the generalized swelling.
okay,
Okay, nephrotic syndrome first time presenting,
okay,
So
okay. I did not listen to that. I missed that. I was keeping my laptop on charge, so
yeah, I agree that you want to see that cover sign, proximal muscle weakness, okay? Only you
yeah.
do the when you get battling it, guys, please. Otherwise, don't do it, okay? Unnecessary.
Okay, okay.
Yeah. All right. Others?
but
Deepti?
it could have been little more systematic, like how she mentioned in the initial general examination, and like mentation, alertness, distress, not distress, and all those things. And then maybe go to that, she already mentioned, like from hands and then going upwards to face and then neck and chest, abdomen, and then peripheral limb edema. And so that could have been more systematic, and differential diagnosis, other more differential diagnosis would have been given for this.
Okay. So for the generalized edema, so what are the differential initial differential diagnosis other than nephrotic syndrome?
So other
Heredity
renal causes
angioedema
can be
can be seen.
there, angioedema, liver failure, cardiac failure, depending how
Hmm.
the anasarca progress, or even anaphylaxis,
Okay, but you need to, reason why it is not
nutrition.
also like,
Why?
so yeah, I agree. Okay, so this possibility of liver failure, but however, I can't see any signs of liver disease here, so it is less likely. Okay, so congestive cardiac failure, so you'll get dependent edema, and so in the cardiac examination, so heart sounds were not on. I didn't get any murmur or any kind of rhythm. So it's less likely it is a heart failure. Protein losing enteropathy still possibility is there with hypoalbuminemia, so that's okay. And other renal causes also, okay, usually get a short stature, pallor, and other things like, so could be sometimes, CKD can have like, generalized edema. So possibility is there, but less likely here because the height and weight and the thing looks normal for the age. Okay. So
Sir,
I was
could
asking,
we keep nephrotic and second one nephritic as well, acute glomerulonephritis or nephritis?
Won't the blood pressure be high on in that?
but yeah, what is the criteria for, okay, so these two, like, and they're different, okay. So nephritic syndrome and nephrotic syndrome. Nephrotic syndrome, what are the requirement, like, what should be there, like, and what are the features should be there to make a
So it
diagnosis?
has to be
So
hypoalbuminemia, hypercholesterolemia, and
Hypercholesteremia,
Edema.
is hypercholesteremia mandatory to make a diagnosis?
no, it's not.
Hypoalbumin edema, hypoalbuminemia.
Important
Generalized,
thing in a nephrotic is a progressive edema and massive.
generalized edema or anasarca is one criteria, okay. Second thing, what is second thing?
It has to be the heavy proteinuria, which means 3+ of protein on dipstick, or if we are doing a urine PCR, then it has to be
Yes,
more than
heavy
200.
proteinuria, or so instead of that, you say nephrotic range proteinuria. Okay,
Mhm.
so that is like urine spot protein creatinine ratio more than 200 milligram per millimoles,
Mm.
or more than
Mm.
3 plus, you can say
Yeah,
spot dipstick. Okay, and third thing is, okay,
hypoalbuminemia.
hypoalbuminemia less than 25 gram per liters. Okay,
Yeah. But
so
I was thinking whether we can put a differential like because it's a clear cut nephrotic syndrome. So we can say differentials like primary causes and secondary causes. Primary is minimal change, and the secondary is causes are like infections can cause or lupus. Although it was not like in this case, we can't say that. But infections like chronic infections, hepatitis, for example, is also one of the causes of.
see, so clinically you try to lot other causes. Okay, so if it is like, nephrotic syndrome, but you need to at least you have to do the spot, that urine dipstick testing actually to make a diagnosis. Okay, you have to prove at least proteinuria there, like, to make a diagnosis, initially. Then you send the investigation. Then after that, you make a diagnosis. I was asking
Dr.
questions.
Moni?
Okay, sorry.
Sorry, continue. I have a question I'll ask in the end.
Yeah. So I was asking about what are the types of, nephrotic syndrome, so you have to say, like, what are the types, guys? Okay, so you're telling typical or typical. I'm not happy with that, actually, those things. Okay, so
Idiopathic, primary and secondary. Primary is idiopathic and secondary other causes like
fantastic.
they have
Fantastic.
told that
Yeah,
hereditary
Drugs, HSP, SLE,
drugs, HSP, SLE,
congenital
infection.
nephrotic
very good.
syndrome.
Fantastic. Okay. So it can be primary or it can be secondary. And there is one more thing, there is congenital form also. So primary, okay, is basically idiopathic, like, so in that case, primary, we keep, like, minimal change nephrotic syndrome and focal segmental glomerulosclerosis and other things, like, membranous proliferative glomerulonephritis, and those things will come. But in case of secondary, yeah, so basically systemic diseases, okay, infections, okay, hepatitis B, HIV, whatever, like an SLE. It could be anything, actually. Okay. Or even malignancy also can be there. Okay. So in secondary, yeah, sometimes nephritic onset nephrotic syndrome also. So that is, you have to keep it in second. Like. Then there is a congenital, nephrotic syndrome, which starts from the, birth, and it's very refractory to treatment, and it's progressive, really worsening condition, basically. So what is that type called as? What is that congenital nephrotic syndrome?
Congenital nephrotic syndrome.
Finish type. Okay, so that's called finish type. Like
Finished.
yeah. Okay, so in case of idiopathic, minimal change is most common, like 95% cases. I agree with that, actually. So, and focal segmental glomerulosclerosis, you can also think. Yeah, so this is how you have to answer, Rehman. Okay, not typical or typical. Okay, please don't tell that.
Okay.
Yeah,
Okay.
yeah,
It's we read Nelson for that. So in Nelson it's written typical, atypical. That's why I said it. But I'll
yeah.
say primary and secondary from now on. I just want to ask that in the guidelines they've mentioned that you will check herpes zoster status. So if you don't have to give vaccine, then why are we checking it then? If my,
Varicella zoster immunity, okay, only if the child with nephrotic syndrome comes in contact with a patient with
Rash
chickenpox,
patient. Yeah.
chickenpox. Okay. So in that case, it is going to help us to decide about giving prophylaxis, okay, in order to prevent the risk of getting that
okay, so
infection.
we are doing it so that if in case he comes in contact, so we have the answer beforehand. Is that the reason?
Yeah, that is the reason.
Okay. Okay.
Yeah. So if the only contact is there, and so usually they are infectious 2 days prior to the onset of the skin rashes, and up to until 10 days after the this thing. So so now recent latest guideline, I'll come to that, actually. Latest guideline says that, okay, just go for the cyclover. Okay, so initially, prophylaxis with a cyclover, but later if the child develops skin rashes, okay, then you can have to give IV, you have to admit and give IV cyclover. Okay, so varicella zoster and other things, nowadays it's not easily available in UK, and it's very costly also. So that's the problem. All right. So that is the answer for you, Rehman. From beginning, I'll tell you how was it. Okay. So Rehman, first of all, thanks for the participation. So it was a bit haphazard, actually. So it was not a systematically done. So initial greeting, introduction, then you have to take permission to examine the child, and after that you talk to the child, how is the child doing, and then you have to do the initial assessment. Okay, so that's a first impression of the child: mentality, alertness, speech. Okay, whether the child is distressed, not distressed, dimensions, weight, height. Those things you did have dimensions, and dysmorphic features also you tried to look for, but it was difficult. That's eye patch was there, and any devices in the surroundings you have to look for. That is also very important. Okay, so after that, then second step you have to go for the general examination. So you did, like, and I think you wanted to check the gait here, like, because you had the thing. Okay, it is a case of nephrotic, probably it is a relapse. That's why child has come. Always try to not to forget what is given in the stem, or what is stem. You don't get like a stem like this in the exam. Examiner just tell you, okay, this is Sadap, 2-year-old boy. Okay, he's having generalized swelling for last 1 week or whatever. So please examine him. This is how you will get the, some background history. That is the stem. Okay. So, and it is coming first time, like the matter. So it is clearly written that first time it is coming. So gait assessment, not a bad idea to do it, but when gait is normal, okay, you should have asked if there is any abnormality of gait. Okay. If I told you waddling gait, then you can go for the GOVA sign. Otherwise, don't do it. Don't waste your time, please. Yeah. So general examination start, doing examination from the starting on the hands and nail beds and, nails and nail bed changes, parallel plugging and those things, and pulse you have to check. Okay, the child was having tachycardia. I told CFT was 3 seconds and poor peripheral pulses, but you didn't recognize that complication. Okay, you should have recognized that child is having hypovolemia. Tachycardia is prolonged CFT, poor peripheral pulses. Okay, so this child needed bolus, normal saline bolus initially. Then you go for the albumin therapy, right? So which
Yeah.
type of albumin you'll give? And
Sorry?
what type of albumin do you give? Is it 20% or 4.5%?
4.5%.
Okay, good. So that's why you have to check for the hypovolemia, the severity of, like, the hypovolemia and the shock and futures you have to check for. Okay, so yeah, and checking pulses, perfusion, blood pressure is very, very, very important. Okay, risk of cellulitis, sepsis, septic shock is very high in these cases actually. So then gradually you look for the arm, forearm, and those things. Okay. So yeah, definitely you should have done the dimension. Dimension you ask for that. Okay. So child was normal for the age. Then head and face and head, like you have to look for the icterus and pallor. Okay. Then nose, oral cavity, ears. Okay. And neck, chest. Okay. Then you go to the abdomen. So then in abdomen, first of all, I would like to go for the abdomen examination. I would like to start with the inspection. You didn't tell that, okay? So inspection you didn't do. Directly went for the palpation. Why did you do that?
I thought there was picture given, so I did the inspection on the picture. You gave the
You
picture
have
in
to
the
look for
beginning.
this. You have to say that what exactly you want to look for in inspection. Okay, so for the abdomen palpation, abdomen examination, I would like to make the child lie on the couch. Okay, I make sure my hands are warm, and I'll make sure child is not having any discomfort in the tummy, abdomen. Okay, so
Hello?
yes, can you hear me? Yeah. So after that, you have to do the inspection, and the inspection. So you have to see whether it's abdomen is generalized swelling is there. Is it in the lower part, upper part, and generalized swelling, the skin over the abdomen? Okay. Any veins, distended veins, umbilical position. Okay. Hernial sides and those things. Okay. So you have to check those things first before you go for the palpation. Palpation, superficial palpation, deep palpation. I agree. You did. Okay. So how do you palpate for the acromegaly, guys, in case of ascites? What is the method?
Sorry, I got disconnected.
No, I'm asking to everyone, okay? So how do you
Uh,
palpate for the acromegaly in case of ascites?
You need to shift the fluid and then you need to palpate.
You have to just dip like this and you have to palpate for the acromegaly, okay? All right, so you did that, okay? Percussion to look for the spans and free fluid, and so child was having septic dullness. Okay, so how do you grade the severity of the ascites, guide based on your findings?
Fluid
Yes.
thrill would be the severe most. Shifting dullness comes the first. And before
Moderate
that, there is,
ascites, illness, okay? If the
yeah,
child is having mild ascites, what is the sign you do, Sarika?
yeah, there is one sign where we
What is that
make that.
sign?
I forgot.
Okay, so what about
Puddle
other
sign? Puddle
puddle
sign.
sign? Very good, puddle
Puddle
sign.
sign. Yeah.
Okay, can anyone explain about it? Open your cameras, guys. Okay, no problem. You can explain how it is done. So, what is the puddle
Yeah,
sign? How to do that?
yeah. The baby or the child, it will be in like a horse-like position or uh, on their knees,
Mm-hmm.
and we'll check by the stethoscope, not by our finger or anything.
Okay, you have to put stethoscope, okay, around the umbilicus, and you try to percuss around the umbilicus. Okay, so because of that the fluid present, okay, minimal fluid present out there. So you will get that the percussion waves, you can hear that actually in the stop. So that is a puddle sign. Sometimes they'll ask you to, do in the exam, guys, okay. I was, okay, when I did my exam, like, when I gave my exam long back, so I was asked to do a puddle sign. Okay. So for the child, and yeah, so that's why they might ask you guys to do that, okay, to remember. So after that, yeah, so auscultation you have to do. I think you missed that auscultation. Did you do Boyle sounds auscultation?
No, I didn't. I thought for GP you only have to do the relevant stuff. So vowel sound isn't relevant here.
No, you can't say that, okay. Still, like, if
Okay.
child is having cellular peritonitis, you will get, so Boyle sounds will be decreased, kind of because of a
Okay.
palliative. Why it is not relevant?
Okay.
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 So then if you get time, like, and you have to go down and look for the pedal edema, and after that other system examination. I'm happy that you did respiratory system examination, the breath sounds and okay, ear entry and those things. And after that, yeah, so cardiac heart sounds actually. So that's important because of the pericardial effusion. Sometimes you'll get muffled heart sounds, okay, distant heart sounds. Okay. Yeah. So after that, you have to summarize. You have
Sir,
to sum.
I
Yes.
have one question regarding
Mm,
this general physical examination. So if we
mm.
have a child with this generalized body swelling, we start from hand and we go and we see the chest and abdomen full exposure. So first we have to on inspection or palpation, do we have to localize apex beat or do we just jump to the abdomen as the baby is having generalized edema, or
Okay.
we'll just auscultate the chest?
So here basically you are supposed to do the abdominal examination first. You have to complete that first, okay? Otherwise, you don't get time in the exam. You miss the findings, important findings in the abdomen, okay? So suppose in case if you don't get time also, just say to complete my examination, I would like to look at apex beat and auscultate for the heart sounds, any muffling or anything is there, or any uh,
कुछ चढ़ा हुआ है क्या महक रहा है
who's that? All right. So yeah, then you can say to complete my examination, I would like to do so and so. Okay. Other thing is that you have to look for the scrotal edema also. It's important, guys, okay, because it indicates severity actually. Okay. All right.
So I offered that in the exam. Do we have to look for it as well?
A child, 2-year-old child, what is the problem? What is the big issue in that?
Okay. I don't know. People were saying that in this exam you only have to offer the examination for the genitalia. You don't have to do it because it's an
Take
exam and they
permission.
know it.
Take permission. Okay. So
Okay.
okay, small child, young child, what is problem there? Like, just say that I'm just going to bring this underpant down, okay, just to see if there is any swelling, anything. Is it okay for you? Just ask mother or father who is there. Take permission to do it.
Okay.
But only that adolescent, when you're dealing with adolescent, yeah, problem is that. So in that case, you just say, I would like to complete my examination by doing the, pubertal, by checking the pubertal status. That's standard staging basically. Okay. So after that, you have to summarize the case. So summary has to be very short and crisp. Okay, you don't have to tell each and everything. Say that today I got opportunity to examine Siddharth, who is 2 years old, is having is brought to the history of generalized swelling for last 1 week and the first time. So on examination, he's well built. He's alert, awake. He's having tachycardia, prolonged CFT in the general examination, along with the poor peripheral pulses, and he's having generalized edema, pedal edema, pitting edema. And the local examination, I found he's having moderate ascites with no aganomegaly. So my first differential diagnosis here, I would like to give nephrotic syndrome. Okay. Why? Then you have to say because of the age group, whatever, like, so generalized edema. Yeah. Further, I would like to confirm it by doing, the urine protein creatinine ratio and albumin levels, serum albumin levels. Okay. The differential diagnosis is you have to tell about liver failure, heart failure, but you have to reason why it is not there. Like, what I told, I already told about a chronic renal failure. Yeah, protein using enteropathy is still possibilities, but where the child is looking, not looking, malnourished. So child is having a normal weight and height, And yeah, so after that, so here, so I would like to inform my consultant, admit the child, you have to say, because child is having signs of hypovolemia. You need to admit this child. Okay.
Okay.
Yeah, I would like to take the weight of the child, and I would like to document the vitals and plot weight, height, etc., from the appropriate growth charts, and look at the previous investigation if there is anything done. Okay. Then I would like to run the investigation. Full blood count, okay, to look for any infection, if there's inflammatory markers. Also, you have to look for in case if the child is having fever or anything, not in this case. And also to look for the, the sometimes hemo concentration are like, WBC counts, might go up and down. So that's why you want to see serum electrolytes, RFTs, LFTs you want to do. Okay, then yeah. So hepatitis A, B, C also they will do. I don't know. Okay, immunoglobulins levels also you have to do. Okay, then you have to do the zoster immune status, like varicella zoster immune status. You have to check it. Okay, and so these are the things you have to do. These are the first line investigation you have to do. Urine protein creatinine ratio, or whatever, like so okay, you can do that, and you have to do the daily weight monitoring, and so blood pressure monitoring, those things, and yeah. So second line investigations, in case if you are suspecting secondary nephrotic syndrome or other differential diagnosis, then you have to go for the ANA, NTDS, DNA, C3, C4 levels, and yeah, those things like HIV, hepatitis B, and those things, serologic can do. So here, first of all, I would like to, for the hypovolemia management, I would like to say acidotic crystalloid 10 ml per kg. Then still if the signs of hypovolemia are there, so then you can go for the 4.5% albumin. Still not responding, having edema and signs of hypovolemia, you can go for 20% albumin. But however, there is a risk of albumin overload, so you have to be careful. So midway, you have to give some small dose of Lasix also. So the management is a multidisciplinary based approach. Okay, so you have to involve, you can say, initial management and long-term management. So initial management here. So yeah, I would like to involve the dietitian and yeah, nephrologist only. It is indicated in case of secondary nephrotic syndrome or steroid dependent or steroid resistant nephrotic syndrome, or if the child is less than 1 year, more than 12 years, or if the child is having hypertension, hematuria, so kidney injury. So in that case only it is nephrologist involved. Otherwise, you have to manage. Okay. So initially here the fluid management you have to tell. Okay. So usually 300 ml per meter square plus previously put like you have to say less than 5 years, so 600 ml. 5 to 10 years, 800 ml. More than 10 years, you have to say 1000 ml. So that's the thing you have to say. Diet is normal diet actually, and then you have to monitor for the you have to monitor put weight and daily these things you have to do. And so whenever edema is there, so yeah, penicillin, I agree with you. Penicillin prophylaxis, pantoprazole, 3P, just remember 3Ps. Okay, so pantoprazole, penicillin prophylaxis, and prednisolone later. Okay, so prednisolone, so you have to give 60 milligram per meter square, 4 to 6 weeks daily, once daily. And after that, you have to make it every alternative day, another 4 to 6 weeks, then try to taper over next 3 to 4 weeks. Then you have to see. So when child is responding to treatment and child is under remission, means urine protein creatinine ratio. Sorry, urine deficit ratio is less. Sorry, please mute yourself. Okay. All right. So if the urine dipstick is less than 1 plus or less than, so yeah, then that child is under remission for 3 consecutive days. It has to be there. So you can discharge a child if the child is accepting orally, responding, edema is coming down, and urine protein creatinine ratio also has come down less than I can say 100. So after 1 month, you have to follow up that child. Suppose if the child is responding to treatment, but they want to go home, but child is not under remission, still, do you want to send the child home, or you want to keep the child?
If they want to go home, we can send them. If if the urine if he's not in the mission, I think if they want to go home, then we can send them. But then we will ask them to follow up more frequently.
Very good. Okay, so you have to ask them to do urine dipstick testing daily, and also come at least twice a week until child goes into remission. And yeah, after 1 month, I agree with you. Okay, so that's common sense actually. So after that, you are going to change the dose. That's why it's important to know. And other than that, you want to know sometimes child may not respond. Okay, so if the child is not responding to the oral daily prednisolone for 1 month, okay, so then you have to label it as a steroid resistant nephrotic syndrome, right? So that is the reason. Expected complications, yeah, risk of infection, cellulitis, UTI, peritonitis, and those things, and yeah, then hypovolemia, so thrombophilic episodes,
Thrombosis.
risk of renal vein thrombosis. Yeah, agree. Blood clot imbalance could be there. Okay, then so these are the things. Yeah. So then other thing is that I would like to educate parents regarding the infection control measures. Okay. So to wear the mask. Okay. Whenever they want to go out, like, and we have to, that have to do hand washing, and whenever somebody is having some infection, I don't keep the child away from them. So yeah. So if the child comes in contact with chickenpox, okay, you have to start, a cycle with initially as a prophylactic treatment, preventive treatment. If the child is developing skin rashes, then you have to go for you have to admit and you have to go for the therapeutic process of the cyclovir. And yeah, so regarding vaccination, usually try to avoid vaccines until 3 months following the daily prednisolone therapy. In update vaccines, you can still give an alternative therapy of prednisolone. Okay, they can give the inactivated vaccines. So yeah. So most of the child, okay, what percentage of the children with the minimal change nephrotic syndrome respond straight away first episode, and after that it's the last episode? What percentage of children will respond to the prednisolone?
Only 20%. They have the relapse rate of around 80%.
No,
What about
minimal change, 80% respond.
Oh,
Yeah,
no, that means
80%
80%,
respond.
okay, respond. I agree, 80% they respond. Okay, I'm asking, like, without any relapse, I'm asking, like, yeah, I agree with Rehman. Okay, so 20 to 40% they will straight away first episode they might respond. Otherwise, rest all, like, 60% they'll 60 to 70% will come out with relapses. It could be infrequent and frequent relapses. What do you mean by frequent relapses, guys?
Frequent is more than
Frequency
2 in 6 months or more than 3 in 1 year.
Fantastic. What is steroid
4, I
dependent?
think 4 in 1 year.
No, more than 3 in 1 year.
Steroid dependent is when the child is on alternate day steroids, the urine albumin starts appearing like more than nil plus. So that is called as a steroid dependent.
Within 2 weeks of stopping daily
Or
prednisolone,
yeah,
alternative, prednisolone. Yes. Fantastic, guys. So well done.
Thank you.
So yeah. All right. Do you have any questions? Welcome. So no, if no questions, okay, we can just generally we can discuss. Do you have any questions?
Yes, sir. Sir, according to this examination only, or we can ask any question?
Anything you can ask.